so medium to large, they will have this. And as one continues to breathe, that pressure increases, causing even further collapse of the lung. So if you can imagine that, this is the lung, and we're going to imagine that, I think I'm actually going to draw it in different colors just to make life easier. So this is the right lung with the visceral pleura attached, and this is the left lung with the visceral pleura attached. And then this is the parietal pleura of the right lung. And parietal pleura of the left lung. Obviously the mediastinum is there, I haven't left enough room, but I'm just really trying to show a point. So let's say if this was a right lung pleura, the left will go on as normal. I may have changed the size, not because I want to, but really, oh, that's normal, don't change the size, leave things as normal. So the left will continue as normal with this cardiac notch there. We're imagining that these sizes are the same, that nothing has changed. However, in the right, because of that introduced space, the lung will start to collapse. So this is a large or medium large pneumothorax. And as breathing continues, that collapse, because obviously let's remember that there is a carina there. I haven't drawn anything anatomically correct. There is the carina there and the trachea in there with the bronchi coming into the lungs. So as the pneumothorax enlarges, it can start there as a, say, larger one. Then the collapsing goes on and the lung loses even more of its volume and becomes smaller and smaller until it's fully collapsed. So it gets pushed towards the left. And as that gets pushed, the mediastinum as well gets pushed towards the left, so there will be a mediastinal shift towards the left as well. And as this pneumothorax continues enlarging as one breathes, this becomes a tension pneumothorax. And what it means, obviously, that this pressure in there is increasing so much that it's pushing the lung towards the left and indeed pushing the mediastinum is being pushed towards the left. So everything gets pushed away from the side of tension, because normally obviously there is zero tension there, but all that pressure pushes things away from the affected side. So that is another way of identifying where the pneumothorax is. So the more things are pushed towards the unaffected side, it then affects the heart as well. So you will have a cardiac embarrassment. I need to spell embarrassment. So you have cardiac embarrassment as well. And the treatment for medium to large pneumothorax is really to aspirate the air. So the first line is to aspirate air, aspiration. And if that does not resolve the pneumothorax, then you move on to a drain, to inserting a drain. I'm tempted to say where it's inserted, but I've only seen one, and I think it's between the 4th to 5th intercostal space, mid-clavicular line. Okay, don't quote me on this, because this is really trying to recall information from years ago. I haven't reviewed that. But then you do insert a drain based on the side and site of the pneumothorax. And the drain, really what it does is the air bubble. So it will keep bubbling while the pneumothorax is there until it stops bubbling. Then obviously keep reviewing with radiology and indeed the clinical symptoms to see if it's resolving. Other supportive measures include oxygen therapy, analgesia, and resting. While these people, with a small, tiny pneumothorax can resolve activity, these people with medium to large, have to rest. You would expect that once you drain the pneumothorax, it will resolve. But if it goes away, resolves for a bit, but then reoccurs, then like if there's a relapse, then the treatment becomes surgical, and you can either do a pleurectomy, just removing that section of the pleura that's causing problems, or you can do a talc pleuredesis. Pleuredesis, I think it's called. All that happens is really you introduce talcum powder into the pleural cavity, to encourage and promote inflammation, and what you hope that the inflammation will do is that it will you inflate the lung and then introduce talcum powder, and then hope that the inflammation will then cause the visceral and parietal pleura to adhere together. So all you are doing really is promoting adhesion of visceral and parietal pleura together, so that that potential space is lost. But what that then does is prevent future collapsing of that space. But then of the affected lung, and air being introduced to that space, because then the formation of adhesions obviously means that there is no longer a potential space. So there is loss of potential space, and we hope that resolves, because then there is no cavity in between the parietal and visceral pleura. The talc, the inflammatory process using talc powder does not usually resolve. It does help, but it doesn't mean that the problem goes away forever. But then that is how you would manage a pneumothorax, really, by trying to by removing the air from the cavity, and then if it's a very large pneumothorax, taking further steps such as using a drain, or indeed referring to surgery if it doesn't resolve. And then The other disease that I really quickly want to look at, I'm just looking at my camera to make sure that it's still recording, that I still have space, is pneumonia. Because of us, I've talked about, you know, the pyema that arises from pneumonia. So pneumonia, it's inflammation in alveoli due to infection. So pneumonia usually happens, the age group that are affected, or the groups that are affected, are elderly people, elderly, the young people, perhaps after an acute respiratory distress syndrome due to an infection. Usually it could be a virus. When I say young, obviously I mean really infants, babies 1 to 2 years old. Here I really mean, you know, the elderly. And people with chronic disorders, such as heart problems, diabetes, and lung problems, pulmonary disorders, like chronic lung disorders, COPDs, asthma, bronchiectasis, particularly cystic fibrosis and bronchiectasis do get a lot of pneumonias due to being prone to infections. People who are immunocompromised, be it from, you know, acquired immune deficiency syndrome, or being on chemotherapy, or being on immunosuppressants. And others are people who are on ventilator support. So these are the groups generally who get a lot of pneumonia. So the causative agents that cause pneumonias can be, I'm going to do this very quickly because I feel as though I've done it when I was doing cystic fibrosis. Can be bacteria, including H. influenzae, strep pneumonia, staph aureus, still regular how to spell that, pseudomonas, I'm sure it will come to me if I've forgotten. And so these are bacteria and viruses, such as the influenza virus. And with bacteria, there is atypical bacteria as well. Atypical. These are opportunistic, mainly opportunistic. And they will usually happen on this group of people. So these are the Legionella, and the chlamydias, and the mycoplasma pneumoniae. So we have our typical. We also have fungi. Again, similar, and we can have aspirational. Again, these are the elderly and unwell people, you know. When I say chronic unwell, I probably mean people on ventilator support and people are really doing unwell. I don't mean people who live with chronic diseases. So aspirational, it's swallowing, you know, from the swallowing reflex, and then things go down the wrong way. Instead of going into the esophagus, it ends up in the trachea, and down into the lungs, down to the bronchi, the lungs, and the alveolar, causing an inflammatory response based on the resident macrophages. Again, I'm not going to talk about the inflammatory response because I've talked about inflammatory response quite a lot. Usually it's always the same. The bacteria, you end up with cell-mediated inflammatory response. The virus, you will end up with Th2 response, particularly the immunoglobulins being targeted at the causative virus. So this will be again things like basophils, but then I don't really want to go into pathogenesis because I think I've covered it quite a lot during the other talks. So with pneumonia, the presenting features are cough, productive, atypical might not be productive, there's yellow sputum, general unwellness. When I mean unwellness, I mean terribly unwellness, with fevers, chills, lethargy, fever, this is a high fever, very high fever, dyspnea, increased heart rate, and increased respiratory rate, which can decrease as one becomes acutely unwell. So these are acutely unwell. There will be pain as well, headaches, and on examination there will be, dullness to percussion, there will be crackles on inspiration. There'll be fine crackles on inspiration, and generalized coarse crackles. And then there will be high resonance, high vocal resonance. So the way that pneumonia is, so this is the clinical picture that patients will present with, and the way it's diagnosed definitively is through, the clinical picture itself. It's always suggestive of pneumonia. So the clinical picture and presenting complaints is usually suggestive, and then bloods will have raised inflammatory markers. You can do cultures to identify the causative agent, and do sensitivity as well, sensitivity testing. Radiology is one of the most useful diagnostic tools, because let's remember, cultures are not immediate, are not instant. They will take some time to culture, more than 24 hours, but radiology is immediately available. And what you find on radiology is consolidation on affected side, and then if there is consolidation and the clinical picture that is suggestive of pneumonia, it's best to just give to treat empirically with amoxicillin. And if it's someone who's allergic to penicillins, then erythromycin or macrolates, shall we just say, will do. So Another thing to do with another thing to bear in mind with pneumonia is that if it's an elderly patient, particularly a community acquired pneumonia, so community acquired pneumonia, specifically in the, well, most especially in the elderly, because really they are the people who get a lot of pneumonia. Younger people, it's usually people with COPD who will get pneumonia, and obviously, you know, CF and bronchiectasis. But it's useful to do the CAB 65 test to test for severity. And what it does is it gives a score out of 7, and this is, you know, it measures confusion, urea levels, urea. If it's more than 7 millimoles per liter, then respiratory rate. If it's more than 30, resp per minute. And then you have to measure the blood pressure. If the systolic is more than 90, well, sorry, I'm so sorry, it's less than 90 millimeters per mercury, or the diastolic is less than 60 millimeters per mercury, then for all of this, if there is confusion, you score 1, 1, 1, 1, 1, 2, 3, 4. And then if they are over 65, years old, you score a 2. So then you put all of that together. If they score, you know, 0 to 1, they can be treated at home, managed just as an outpatient at home, but they will have to be reviewed in 2 weeks' time to make sure that all is well, really, or follow up closely, just to make sure. Don't even wait 2 weeks, actually. Close follow up, in fact. And then if the score is between 2 and 3, they must be admitted to hospital and treated as an inpatient. Anything less than 5 is intensive care. So that's how you use the CAB 65. But obviously the CAB 65 is much more specific to the elderly, because due to the age being inserted there. But then it just tells how to manage a patient, really, and it's quite useful for that. So you can either discharge someone who has a low CAB 65 and then follow them up closely, or you can indeed, if it's between 2 and 3, you can treat them as an inpatient. Admit and treat as an inpatient is recommended. Anything more than 5, they have to go into ICU. So the treatments that are given for community acquired is the amoxicillin. So you can give amoxicillin. The B-lactams. We can also give erythromycins, and then give us broad. Well, this is broad spectrum, obviously broad spectrum, to cover any atypicals, just in case. However, if they are not resolving, you know, if they are not improving, you can then add second generation quinolines, particularly if it's someone with CF, and And if they are to be admitted as well, then have to give, it's recommended that they can then receive cephalosporin and corticosteroids. And then if it's a hospital-acquired pneumonia, we expect that it's from an opportunistic bacteria. It's particularly, things like Legionella, which can breed in air conditioning if the air conditioning is not maintained properly. Or things like MRSA, methicillin resistant stuff. So they will then need vancomycin and broad spectrum and quinolines. I think I forgot Pseudomonas in broad spectrum and quinolines. And again, it's all about managing, reviewing, and making sure that people get better. So with pneumonia, usually people will recover. Say so, particularly people who are treated at home will recover within a week. So within 5 to 7 days, they'll start to feel better and improve. However, recovery is dependent on, say, underlying pathology. So if someone obviously has an underlying lung condition, like a COPD patient, we expect them to get better in weeks. It can even be up to 12 weeks of of them still feeling unwell and trying to recover. However, they will start to improve and feel better as long as therapy is changing, as long as our therapy is working. And obviously, if it's not working, then it's all about going back to the bloods to find what the specific pathogen is, and then changing to to using an antibiotic that the pathogen will be sensitive to. People in hospital, again, it's still the same picture. We expect some improvement in the first week, and then treating any other conditions that are there until they get better. However, people who are hospitalized, there is a high risk of mortality in anyone who gets hospitalized with pneumonia. It's about 10% in non-ICU, and about 30 to 50% of all people who go into ICU will die of pneumonia. So this is quite serious, really. However, the management again is antibiotics, analgesia, oxygen support, fluids support, and reviewing clinically and with radiology, and indeed with bloods and cultures, particularly for people who with community pneumonia who are then admitted, because chances are they will catch a hospital-acquired infection and get even more unwell. So it's important to review and then redo the cultures after 3 days, because it takes about 3 days for someone to then catch a hospital-acquired infection. Usually, when treated well, pneumonia will eventually resolve. However, it's possible to then have complications from that, and complications will be an empyema, which I've discussed. Again, it has to be aspirated, drain, and then antibiotics, specific antibiotics from that. Pneumothorax, again, can occur. I've talked about that. Fluid. Well, this is fluid anyway, but any exudates, which are not specifically empyema. There can be cardiovascular diseases and the exacerbation of the underlying condition, if there is any, of primary disease. So that has to be managed as well to make sure that someone gets better and they get to go home. That's the most important thing, for someone to get better and go home. So in this last section, I've just briefly discussed pneumonia, from who gets pneumonia, how it's diagnosed, how the CAP 65 is used, and how the management plan for pneumonia and the complications that can arise from pneumonia. And I want to say, I want this to be the last section of respiratory talks that I have done, but I know that I haven't done asthma. But however, asthma and COPD are quite similar in terms of pathogenesis, except for that asthma is obviously, you can reverse that restrictiveness. However, the treatment is similar, and the acute exacerbation, the presentations are similar. The only difference is that obviously with COPD, there's usually an infection that's underlying, and that has to be treated. Whereas with asthma, it's more about maintaining the airways, reducing inflammation, and making sure that we have a patent airway for gases exchange to occur before someone gets tired in an acute exacerbation and they fall into type 2 respiratory failure. Then they will be in trouble. So in the next series of talks, I'll be focusing on rheumatology and orthopedics. And yeah, that's it for now.